All right, so let's dive into a topic I think you guys are all too familiar with in your
Oh,
practices.
yeah.
Female infertility. It's a complex issue
Mm-hmm.
and, can be really tough for patients and for us as
Yeah,
doctors
yeah.
to kind of work through and navigate.
Yeah.
Um, we've got a stack of the latest research here, so
Okay.
ready to kind of extract the most useful nuggets for you all.
Awesome. Sounds good. I'm ready.
Okay, great.
Always good to refresh this stuff, especially
Yeah,
with how fast it changes.
totally. So first things first, how about we make sure we're all on the same page about like what
Yeah.
infertility actually means,
Yeah.
in the clinical setting.
Okay, yeah. So the American Society for Reproductive Medicine,
Okay.
ASRM,
Mm-hmm.
they lay out a pretty clear definition. It's not just about like time spent trying,
Yeah.
but it's really about needing medical intervention
Okay.
to achieve a pregnancy.
Got it.
So that could mean anything from medications to donor eggs or embryos.
Okay, so it goes beyond just like not getting pregnant after X months.
Right.
What are the actual like timelines we should be considering
Okay.
when a patient comes in with concerns?
So ASRM recommends evaluation after a year
Okay.
of unprotected intercourse
Right.
for women under 35,
All right.
but after just 6 months for those 35 and older.
Okay.
And then for women over 40, we often just jump right into evaluation
Yeah, that makes sense.
without even waiting.
Given the age factor and how that kind of plays
All
into
right.
impacts things. Speaking of age, the research really highlights that most pregnancies
Yeah.
happen within the first 6 months of trying, which kind of surprised me.
Right, I know.
Yeah.
It's like you'd think it would be a little more spread out, but
Yeah.
really emphasizes that for a lot of couples, it's about timing and a bit of luck early on.
Yeah, for sure.
Yeah.
So what's the big picture in terms of like how widespread is this issue?
Okay, so globally, a whopping 1 in 6 adults face infertility.
Wow.
At some point, according to the World Health Organization,
So way more common issue than a lot of people realize.
that is a staggering statistic now when we talk about female infertility specifically.
Okay.
Are there particular groups of women who are more likely to experience it?
Yeah, age, as we touched upon, is a major factor.
Okay.
After 30, the prevalence really starts to climb.
Yep.
And across all age groups,
Okay.
women who haven't given birth before
Okay.
tend to have higher rates of infertility.
I wonder what contributes to that difference for women who haven't been pregnant previously.
Yeah, there are a lot of theories,
Hmm.
but nothing definitive yet.
Okay.
More research is definitely needed there.
Yeah, for sure. All right, so we've covered like how common it is and the age factor.
Mhm.
Let's get into the nitty-gritty. What are the root causes?
Okay, so before we like dive into the female-specific causes,
Yeah,
we can't forget that infertility is often a team effort,
right.
or rather a lack thereof.
Yeah.
So a World Health Organization study
Okay.
showed that around 37% of cases are due to female factors, right? 8% male factors,
Okay.
and a combined 35% have both playing a role.
So it's crucial to remember it's not always solely on the woman's side.
Exactly. It's a shared journey.
Yeah.
And evaluation of both partners is key.
Okay.
It's also important to note that in about 5% of cases,
Go.
even after thorough testing, we don't find a specific cause.
Okay.
And that's what we call unexplained infertility.
That must be a tough conversation to have with patients.
It is.
Yeah. So for female infertility specifically,
Okay.
what are the most common causes we're likely to see in our practices?
Okay, so a large population-based study found that the usual suspects are male factor infertility
Okay.
at 26%, ovulatory dysfunction at 21%,
Okay.
tubal damage at 14%, endometriosis at 6%,
Okay.
and then that unexplained category coming in at 28%.
Lots to unpack there.
Yeah.
For ovulatory disorders, which affect a quarter of infertile women,
Yeah.
how can we effectively categorize them
Okay.
to guide our thinking? So while there are a few classification systems out there,
Yeah.
you'll likely encounter the WHO's 3 categories
Okay.
most often.
Okay.
And the most common one you'll see in practice is class 2,
All right.
normogonadotropic normoestrogenic anovulation.
So that's one where like hormone levels might look normal, but ovulation is still irregular
You got it.
or absent. I'm guessing PCOS falls under this category.
PCOS is a frequent culprit in these cases.
Okay.
And it's important to remember its impact goes beyond just fertility. It's a complex endocrine disorder
Yeah.
that requires careful management.
Makes sense. Now, we can't talk about ovulatory disorders without addressing the elephant in the room
Right.
and its effect on egg quality.
Absolutely. It all comes down to ovarian reserve.
Okay.
The quantity and quality of a woman's eggs.
Mm-hmm.
Remember, a female fetus starts with millions of follicles,
Yeah.
but that number dwindles throughout life.
And it's not just about the number, right? The quality of those remaining eggs
Exactly.
declines with age, too.
The older the eggs, the higher the chances of chromosomal abnormalities,
Right.
making fertilization and healthy embryo development
Yeah.
much trickier. And unfortunately, factors like smoking,
Yeah.
radiation, and even autoimmune diseases
Wow.
can speed up that decline.
That makes it even more crucial to counsel patients about lifestyle factors
Yeah.
and how they can impact their fertility.
Right.
What about ovarian cysts?
Okay.
Do they always spell trouble for conceiving?
Not necessarily. Research shows that small ovarian cysts,
Okay.
particularly those endometriomas,
Okay.
might not significantly impact fertility.
Interesting.
Surgery to remove them could even be more detrimental to ovarian reserve than just monitoring them.
So it's not a one-size-fits-all approach when it comes to
Right.
ovarian cysts. Moving on, we've got fallopian tube abnormalities and pelvic adhesions
Okay.
on our list of common causes.
Right, so those are the structures responsible for that crucial egg and sperm rendezvous.
Yeah.
Any blockage or damage there throws a wrench in the whole process.
Yeah.
And the primary culprit for these issues is pelvic inflammatory disease, or PID,
Okay.
often caused by infections like chlamydia or gonorrhea.
So another area where stressing safe sex practices
Yes.
to our patients is really important.
Absolutely. Preventing those infections can go a long way in preventing future fertility troubles.
For sure. Beyond PID, endometriosis can also cause blockages
Right.
with that endometrial tissue growing outside the uterus.
Yeah.
And previous surgeries or infections can lead to adhesions
Mm-hmm.
that disrupt the fallopian tubes.
Yep.
It sounds like there's a whole host of potential culprits for fallopian tube problems.
There are.
Now let's shift gears and talk about the uterus itself.
Okay.
What kind of abnormalities in that department
Right.
can contribute to infertility?
Well, the uterus is the ultimate destination for a fertilized egg.
Yeah.
So its structure and function are critical.
Right.
Uterine fibroids, those benign, smooth muscle tumors,
Okay.
are quite common.
Yep.
While many are asymptomatic.
Yep.
Those that protrude into the uterine cavity
Okay.
can lower pregnancy and implantation rates.
So they're essentially getting in the way.
Precisely.
Okay.
And we also see uterine anomalies like a septate uterus
Okay.
with that dividing wall.
Mhm.
These are often linked to recurrent pregnancy loss.
Okay.
So early identification is key.
Are there any other uterine issues we should be on the lookout for?
Endometrial polyps
Okay.
and adhesions within the uterus,
Okay.
called synechiae, might also play a role, but
Yeah.
the research is still a bit murky on that front.
Yeah, it's always fascinating how much we're still learning about all these
Oh, yeah.
intricate processes. What about something I've always been curious about?
Okay.
Luteal phase defect. Is that a real deal when it comes to infertility?
That's a hot topic.
Yeah.
There's been a lot of debate about this one.
Okay.
So the theory is that abnormalities in the corpus luteum,
Okay.
the structure that forms after ovulation, mess with progesterone production, which is essential for that uterine lining to be ready for implantation.
Right. So inadequate progesterone could theoretically cause problems with implantation.
Right, but here's the thing.
Oh.
ASRM doesn't consider luteal phase defect a definitive standalone
Okay.
cause of infertility.
Okay.
So while low progesterone levels might warrant further investigation,
Yeah.
there's no real consensus on diagnosing or treating it
Got it.
as a primary infertility factor.
Okay. So we can cross that off our definitive causes list
For now.
for now. Before we wrap up this part of our deep dive,
Okay.
we need to talk about endometriosis, which I know you're passionate about.
I am absolutely. It's a condition that deserves a lot of attention.
Yeah.
Endometriosis can wreak havoc on fertility in several ways.
Okay.
So the endometrial tissue growing outside the uterus
Yeah.
can lead to those pesky pelvic adhesions we talked about, which can disrupt the fallopian tubes,
Mm-hmm.
but it can also directly impair ovulation and make the pelvic environment hostile to implantation.
So it's a triple threat.
Yeah,
And you're right, it's often underdiagnosed,
it is.
which makes awareness all the more important. I'm already feeling much more informed
Good.
about the common causes of female infertility.
Awesome.
Ready to move on to the evaluation process in part 2.
Definitely understanding the steps involved is crucial for providing our patients with the best care possible.
Absolutely. All right, we'll see you next time.
Sounds good.
Welcome back. So far, we've tackled the what and the why of female infertility.
Right.
Now let's walk through the how we approach evaluating a patient
Okay.
who comes into our office with concerns about conceiving.
All right, let's map out that roadmap.
Okay.
So the first question is, when do we initiate the evaluation process?
Yeah, I'm all ears. What are the magic numbers we should be keeping in mind?
So for women under 35,
Okay.
it's generally after a year of regular unprotected intercourse
Okay.
without a pregnancy.
Right.
But for those 35 and older, we cut that time frame in half.
Okay.
6 months is our benchmark for starting the evaluation.
Okay, so that age factor kicks in. Again, makes sense. Are there any situations where we might want to fast-track the evaluation?
Absolutely.
Even for younger women?
Irregular cycles,
Okay.
known risk factors like endometriosis or past pelvic infections,
Okay.
any previous pelvic surgery, these all warrant a quicker move to evaluation.
So we're really tailoring it to the individual patient, not just going by a rigid timeline.
Exactly.
Okay, once we've decided to initiate the evaluation, what's our first move?
So the golden rule
Yeah.
is to evaluate both partners concurrently.
Right.
We can't assume the issue lies solely with the woman.
Right. It's a team effort, or at least it should be.
Exactly. By assessing both sides, we get a clearer picture of what's going on
Yeah.
and can better target our interventions.
Now, I imagine this whole process can be quite emotionally charged for couples.
Oh, for sure.
How do we navigate that aspect as their physician?
You're absolutely right. Infertility can be a huge source of stress, anxiety, and even relationship strain.
Yeah.
Being sensitive and supportive throughout the evaluation
Yeah.
is just as important as ordering the right tests.
So we're not just treating the physical aspects, but acknowledging the emotional impact as well.
Precisely, we're treating the whole person.
Okay, so we're meeting with a couple for their infertility evaluation. What are the essential components
Right.
of that initial assessment?
We start with the cornerstones.
Good.
A comprehensive history and physical exam for both partners.
All right, let's break those down, starting with the history. What kind of details are we looking for from the female partner?
So for the female partner, we want a detailed menstrual history.
Okay.
How often are her cycles? What's her flow? Like, does she experience pain or other symptoms?
Okay.
This helps us understand if ovulation is happening regularly
Mm-hmm.
and if there are any red flags like severe menstrual cramps, which could point to endometriosis.
So we're looking for clues in her cycle itself.
Yeah.
What else is crucial to uncover in the history?
A full rundown of her medical, surgical, and gynecologic past.
Okay.
Any past infections, especially those STIs that could lead to PID.
Okay.
Any surgeries and any medications she's taking, as some can affect fertility.
Mm-hmm.
We're also interested in her obstetric history. Any
Got it.
previous pregnancies, miscarriages, or ectopic pregnancies?
Lots of ground to cover there. And I'm guessing a thorough sexual history is important as well.
Absolutely.
Yeah.
We need to know about frequency of intercourse, any difficulties they experience,
Okay.
and if they're using any lubricants, as some can be harmful to sperm.
Yeah, it sounds like a pretty in-depth and potentially sensitive conversation.
It can be,
Yeah.
but those details can provide valuable insights.
Sure.
We also can't forget about family history.
Okay.
Any relatives with infertility, birth defects, genetic conditions, those can hold clues too.
Of course. And lifestyle factors are always relevant.
You got it. Age, occupation, exercise habits, stress levels,
Yeah.
diet, weight fluctuations, smoking, alcohol, and drug use. All of these can have a significant impact on fertility.
Wow. We're gathering a wealth of information from the history alone. What about the physical exam?
Right.
What key areas are we focusing on there?
So we start with the basics: height, weight, BMI calculation,
Okay.
and noting fat distribution, as both extremes of BMI and abdominal obesity can be associated with decreased fertility.
Okay.
We also do a thorough thyroid exam,
Okay.
feeling for any enlargement or nodules.
And of course, no reproductive evaluation would be complete without a pelvic exam.
You're absolutely right.
Yeah.
During the pelvic exam, we're looking for signs of infection, any tenderness or masses,
Okay.
and assessing the size, shape, and mobility of the uterus and ovaries.
Okay, so we've got our history and physical done, which feels like a solid foundation.
Mm-hmm.
What's next on the evaluation agenda?
Next up, it's time for the lab and imaging tests.
Okay.
And we're going to kick things off with a semen analysis for the male partner.
Right, we can't forget about his role in this process. What exactly are we analyzing
Right.
in that semen sample?
We're looking at several key factors, including volume, sperm count, motility,
Okay.
and morphology, which refers to the shape of the sperm.
Okay, so we're checking to see if his swimmers are up to par.
Exactly. And a crucial point to remember,
Yeah.
that semen sample needs to be collected and transported properly
Okay.
to get accurate results any mishandling can skew the findings.
Good point. Now, shifting back to the female partner, what testing do we do to assess her side of the equation?
So our next focus is on ovulatory function.
Okay.
Are those eggs actually being released?
Makes sense. If there's no egg, there's nothing to fertilize.
Yeah.
How do we go about determining if ovulation is happening?
So the simplest way is often the most informative.
Okay.
Asking the woman about her cycles.
Okay.
Regular cycles with those telltale signs of ovulation, breast tenderness, bloating that Mittelschmerz twinge some women experience
Yeah.
are good indicators.
Yeah. So a detailed history can go a long way, but we can also back that up with some lab tests, right?
Absolutely. A mid-luteal serum progesterone level,
Okay.
drawn about a week before her expected period, is a common test.
Okay.
Progesterone is produced after ovulation.
Okay.
So a level above a certain threshold, usually 3 nanograms per milliliter, confirms that an egg was released.
Okay. That's straightforward enough.
Mm-hmm.
What other tools do we have in our ovulation assessment arsenal?
Over-the-counter ovulation predictor kits
Oh, yeah.
are another option.
Okay.
They detect the surge in luteinizing hormone, or LH.
Yeah.
That happens right before ovulation.
I've seen those advertised. They seem pretty user-friendly.
They are, and
Yeah.
they can be quite accurate in predicting that ovulation window.
All right. So we've confirmed ovulation is happening.
Okay.
What's the next step in our evaluation process?
Next up, we delve into ovarian reserve,
Okay.
that all-important quantity and quality of her eggs.
Back to the age factor again.
Yeah.
We know that egg quality declines over time. But how do we actually assess that in a clinical setting?
So we have a few key tests
Okay.
we often use in combination
Yeah.
to get a comprehensive picture.
Sure.
One common one is a day 3 follicle stimulating hormone, or FSH level.
D3, so the third day of her cycle.
Exactly. We measure it then because in women with a good ovarian reserve,
Oh, yeah.
the ovaries are producing enough estrogen to keep FSH levels low.
So if that FSH level is high on day 3, it could signal that our ovarian reserve is lower than we'd like.
Exactly. It might mean there are fewer eggs left or that their quality is compromised.
Okay, so that's one piece of the puzzle. What other tests help us assess ovarian reserve?
The clomiphene citrate challenge test, or CCCT,
Okay.
is another tool in our toolbox.
That one sounds a bit more involved. What does it entail?
So the woman takes clomiphene citrate,
Okay.
a medication that stimulates ovulation,
Yeah.
for a few days, and then we check her FSH levels on day 3 and day 10 of her cycle.
And what's the rationale behind that?
Similar to the day 3 FSH test, if those levels are high after taking clomiphene.
Yeah.
It suggests a diminished ovarian reserve.
Okay.
It's like we're giving her ovaries a nudge
Yeah,
and seeing how they respond.
I see. So we're looking for a robust response to the medication. Are there any other ovarian reserve tests in our repertoire?
Yes. We can also measure anti-Mullerian hormone, or AMH.
Ah, AMH. I've definitely heard of that one. What does it tell us?
So AMH is produced by the cells in the ovaries that surround the developing eggs.
Okay.
The level of AMH in the blood reflects the number of those developing eggs,
Sure.
giving us a snapshot of ovarian reserve.
So higher AMH is generally a good sign, meaning there's a larger pool of those developing eggs.
You got it.
Okay.
And conversely, a lower AMH suggests a smaller pool
Yeah.
and potentially diminished reserve.
Okay, that one's pretty straightforward. Any other ways to assess ovarian reserve?
Yes, we can also do an antral follicle count, or AFC.
All right.
This involves a transvaginal ultrasound
Okay.
to count the number of antral follicles, those little fluid-filled sacs in the ovaries
Yeah.
that contain the developing eggs. So the more we see on ultrasound, the better the ovarian reserve, right?
Exactly.
Wow. There are quite a few tests to consider for assessing ovarian reserve. How do we decide which ones to order for a particular patient?
So it really depends on her individual circumstances.
Yeah.
And what we've already learned from her history and physical exam,
Right.
sometimes we start with 1 or 2 tests
Okay.
and then add more if needed.
So we're constantly evaluating and adjusting our approach as we gather more information. Makes sense. What's the next step in our evaluation journey?
Now we shift our focus to the fallopian tubes and uterus,
Okay.
making sure there are no blockages or structural abnormalities that could be hindering conception.
All right. We need to check that those pathways are clear. What tests help us visualize what's going on in there?
One of the most common tests is a hysterosalpingogram, or HSG.
HSG.
Yeah.
I remember learning about this one in med school. Could you give us a refresher?
Sure, it's an X-ray procedure
Okay.
where we inject a contrast dye through the cervix into the uterus and fallopian tubes.
And what are we looking for on those X-ray images?
So we want to see that dye flow freely through the fallopian tubes
Okay.
and spill out into the abdominal cavity, which means they're open.
Okay.
We also assess the shape of the uterine cavity, checking for any abnormalities
Like,
could be causing problems.
so the HSG gives us a two-for-one deal information about both the tubes and the uterus. I've also heard that it can sometimes be therapeutic as well.
You're right. In some cases, that dye flush can actually dislodge minor blockages in the tubes,
Interesting.
potentially improving the chances of natural conception. It's a nice little bonus.
Amazing how a diagnostic procedure can sometimes have a therapeutic effect. Are there any other tests we use to evaluate the fallopian tubes and uterus?
A sonohysterogram
Okay.
is another option. It's
Right.
similar to an HSG, but uses ultrasound instead of X-rays.
So less invasive approach for visualizing those structures.
Exactly. We inject saline solution into the uterus and then use ultrasound to visualize the uterine cavity and fallopian tubes.
All right, so we've got the HSG and the sonohysterogram. What about laparoscopy? When does that come into play?
So laparoscopy is a surgical procedure, so it's reserved for specific cases.
Okay.
It allows us to directly visualize the pelvic organs
Okay.
and is often used to diagnose and sometimes treat endometriosis.
So not a routine part of the initial evaluation, but a valuable tool when we suspect endometriosis or other pelvic pathology.
Precisely. It's important to emphasize that the specific tests we order
Yeah,
are always tailored to the individual patient and their unique situation.
right. It's all about personalized medicine.
Exactly. We're constantly adapting our approach as we gather more information
Right.
and refine our understanding of the patient's specific needs.
Well said. Once we've completed the evaluation, we have all this valuable data
Yeah.
to help us create a personalized treatment plan.
Which leads us to the next part of our deep dive,
Yes.
treatment options for female infertility.
I'm ready to dive into that in part 3.
Me too. It's an area where we've seen tremendous progress in recent years, offering hope to many couples who are struggling to conceive.
Welcome back to our deep dive into female infertility. So we've explored the causes, the evaluations,
Right.
and now the part that I think brings hope to our patients' treatment.
It's definitely an area where we've seen some incredible advancements, giving us more options than ever before.
So when we're creating a treatment plan for a patient, what are the guiding principles
Okay.
we should keep in mind?
So the overarching goal is always twofold:
Okay.
to correct any reversible causes and find strategies to overcome the irreversible ones.
Makes sense. So we're essentially targeting those underlying causes
Yeah,
we discussed in part 1 and tailoring our treatment approach accordingly.
exactly. And regardless of the specific cause, there are some general lifestyle modifications that we recommend across the board.
Like the good old eat healthy and exercise spiel.
Well, those are definitely part of it, but specifically smoking cessation, achieving a healthy weight, and reducing alcohol and caffeine intake can significantly impact fertility.
Those are great pieces of advice for overall health, not just for those trying to conceive.
Absolutely. Healthy habits create a healthy body, and that's the foundation for a healthy pregnancy.
Okay, so those are our foundational lifestyle recommendations.
Yeah.
Now let's get into the specific treatment options for those common causes we've been discussing. Let's start with ovulatory disorders. How do we typically approach treatment in those cases?
So the treatment strategy really hinges on the underlying cause and the specific type of ovulatory disorder.
Yeah.
Remember those WHO classifications we talked about earlier?
I do class 1, class 2, and class 3, and I recall you saying class 2 that normogonadotropic, normoestrogenic anovulation
Right.
is the one we're most likely to encounter in our practices.
You've got a great memory, and you're absolutely right. PCOS often falls under this category.
Okay.
And for these patients, weight modulation is often the first line of treatment.
Okay.
Even a modest weight loss of 5 to 10% can help jumpstart ovulation.
It's amazing how even small changes in weight can have such a big impact on hormone balance.
It really is. And if weight loss alone isn't enough, medications like clomiphene citrate or aromatase inhibitors
Yep.
can be very effective.
Clomiphene is a classic for ovulation induction, right? How
Yeah.
does it work? It's magic.
So clomiphene is a selective estrogen receptor modulator, or SERM.
Okay.
It essentially tricks the brain into thinking there's not enough estrogen circulating.
Okay.
This prompts the pituitary gland to release more follicle-stimulating hormone, or FSH, which in turn stimulates the ovaries to produce those precious eggs.
So it's like giving the ovulation process a little pep talk.
Yeah.
What about aromatase inhibitors?
Yeah.
How do they differ from clomiphene?
So aromatase inhibitors work by blocking the production of estrogen, which, similar to clomiphene, can also lead to increased FSH production and ovulation. They tend to have some advantages over clomiphene, including a lower risk of multiple pregnancies and fewer side effects.
Fewer side effects are always a welcome bonus. Are there any other medications in our ovulation induction toolkit?
Yes, sometimes we turn to gonadotropin therapy, which involves directly injecting hormones like FSH and LH.
Okay.
It's a more potent approach, but requires closer monitoring to make sure we're not overstimulating the ovaries.
Okay, so that one's reserved for more stubborn cases. What about metformin?
Right.
I know that's often used for PCOS, but it's not directly an ovulation induction medication, right?
You're right. Metformin is primarily used to treat type 2 diabetes,
Yeah.
but it's also a helpful tool for women with PCOS. It improves insulin sensitivity, which is often an issue in these patients,
Right.
and that can help regulate those hormone imbalances that contribute to irregular ovulation.
So it's working more upstream, addressing the underlying metabolic issues in PCOS.
Exactly. Now, in some cases, medications and lifestyle changes alone aren't enough to get those ovaries back on track.
Yeah.
We might then consider a procedure called laparoscopic ovarian drilling.
That sounds pretty intense. What exactly does it involve?
It's a minimally invasive surgery where we use a laser or heat to destroy small portions of the ovary.
Okay.
This can sound scary, but it's actually quite effective in reducing androgen production, which is often elevated in women with PCOS,
Yeah.
and it can help restore ovulation.
So it's like a targeted reset for the ovaries, helping them regain their hormonal balance.
You could think of it that way, and for
Mhm.
women with hyperprolactinemia, high levels of the hormone prolactin,
Okay.
dopamine agonists like bromocriptine
Yeah.
can help lower prolactin levels and restore normal ovulation.
Okay, so we've got a good range of options for tackling ovulatory disorders. Now, what about those tricky fallopian tube problems?
Right.
What are our treatment strategies when those are the culprits?
So fallopian tube blockages or damage can be a bit more challenging to address. If the blockage is at the end of the tube closer to the ovary, a distal obstruction,
Okay.
surgery might be an option.
Okay.
Procedures like fimbrioplasty or neosalpingostomy can help restore patency,
Okay.
allowing the egg and sperm to meet.
So it's like clearing the roadblocks for those traveling gametes.
Exactly. However, surgery isn't always successful,
Mm.
and there is a risk of the tubes becoming blocked again.
Right.
And if the damage is extensive, surgery might not be feasible at all.
So what's our next move in those tougher cases?
In vitro fertilization, or IVF,
Yes.
is often the best option for women with significant tubal damage.
IVF bypasses the fallopian tubes entirely.
Right.
Remind us how that process works.
So IVF involves fertilizing the egg with sperm in a lab setting,
Okay.
creating embryos,
Yeah.
and then transferring one or more of those embryos directly into the uterus.
It's amazing how far reproductive technology has come. Are there any downsides to IVF that we should be aware of?
It's definitely a more complex and expensive treatment than other options.
Yeah.
It also requires multiple clinic visits, hormone injections, and close monitoring throughout the process.
And let's not forget the emotional toll it can take on patients.
Absolutely. IVF can be a roller coaster of emotions with high hopes and potential disappointments along the way. It's essential to provide our patients with compassionate support and realistic expectations throughout the journey.
Well said. We've talked about ovulatory disorders and fallopian tube issues. Now let's tackle endometriosis.
Okay.
How do we approach treatment when that's contributing to infertility?
So endometriosis is a tough one because it can affect fertility in so many ways. Treatment is often multifaceted, meaning we might use a combination of approaches
Yeah.
depending on the severity and the patient's individual circumstances.
So it's a highly personalized approach.
Uh,
What are some of the tools we might use in these cases?
We often start with medications to suppress the growth of that endometrial tissue.
Okay.
Hormonal contraceptives or gonadotropin-releasing hormone agonists or GnRH agonists are common options.
So we're aiming to control the endometriosis itself, preventing further damage, and hopefully improving the environment for conception.
Exactly, but if medication alone isn't enough, or if the patient has significant adhesion surgery to remove those endometrial implants, and any scar tissue might be necessary,
And if the patient is still having trouble conceiving after those treatments,
then we might consider ovulation induction, often using medications like clomiphene or gonadotropins combined with intrauterine insemination or IUI.
remind me how IUI works.
So IUI involves placing a concentrated sample of sperm directly into the uterus,
Okay.
bypassing the cervix, and increasing the chances of the sperm reaching the egg.
So we're giving those sperm a little shortcut.
Exactly, and if all else fails or if the endometriosis is very severe, IVF might be the best path to parenthood.
It seems like IVF is a powerful tool for addressing a wide range of infertility challenges.
It truly is. It's a game changer for many couples who otherwise might not be able to have biological children.
Okay, we've covered some of the heavy hitters in female infertility.
Mhm.
What about uterine factor infertility?
Okay.
How do we address those abnormalities that can hinder implantation?
So it's important to remember that not all uterine abnormalities require treatment. But if we find a submucosal fibroid distorting the uterine cavity,
Yeah.
we'll likely recommend surgery to remove it.
And what about polyps or adhesions within the uterus?
We can often remove those hysteroscopically, which is a minimally invasive procedure using a thin lighted scope inserted through the cervix.
Okay, and if the patient has a septate uterus, that dividing wall within the uterus, can we fix that?
Absolutely. That can also be corrected surgically, usually with a hysteroscopic procedure as well.
So there are effective surgical options for addressing a variety of uterine abnormalities.
There are, and early diagnosis to treatment of these conditions can significantly improve a woman's chances of having a successful pregnancy.
What about cervical factor infertility? How do we approach that?
So cervical factor infertility, where there's an issue with the cervical mucus or the opening of the cervix,
Yeah.
is often treated with, you guessed it, intrauterine insemination or IUI.
Ah, that trusty IUI, bypassing the cervix and delivering the sperm directly to the uterus, and if IUI doesn't do the trick.
Then IVF might be the next step.
It seems like IVF really is a common thread throughout so many of these treatment options.
It's such a versatile and powerful tool in our reproductive arsenal.
Okay, last but certainly not least, let's talk about unexplained infertility. How do we approach treatment when we've exhausted all the tests and still can't pinpoint a specific cause?
Unexplained infertility can be incredibly frustrating for both the patient and the physician. But it's important to remember that it doesn't mean all hope is lost. We often recommend a stepwise approach, starting with less invasive options
Okay.
and then moving to more advanced treatments if needed.
So it's like a tiered approach, starting with the simplest interventions and escalating as needed.
Exactly. We might start with clomiphene citrate or letrozole, those ovulation induction medications we talked about earlier combined with IUI.
Okay.
If that doesn't lead to success, we might move on to gonadotropins with IUI, and if those treatments fail, IVF might be the next step.
So even when the cause remains a mystery, we still have a variety of paths to explore.
Absolutely. And it's important to remember that research is constantly evolving in the field of reproductive medicine. What seems impossible today might be achievable tomorrow.
That's a hopeful note to end on this. This has been such an incredibly informative deep dive into female infertility.
Yeah, it's been fun.
I feel much better equipped to guide my patients through this complex journey.
Good. I'm glad to hear that.
Thank you for sharing your expertise with us today.
It's been a pleasure.
And to all of our listeners out there, thank you for joining us for another deep dive into the complexities of medicine. We'll see you next time.